For the chair, one is JSK from Madrid, GlaxoSmithKline, Respira Vida. For the second year in a row, it's an honor and a pleasure to participate in this meeting of Fenaer, or Congress of Fenaer, the National Federation of Associations of Patients, Allergic Patients, and with respiratory diseases, thanks to its president, Javier Palicio, and the whole board. We are going to approach the COPD, this very prevalent pathology paradigm of chronic disease that is also concerning for us. And we are going to make a true coalition around the patient with COPD. Patients with COPD are chairing this panel of this satellite symposium. The title of the symposium is very illustrative. With you, I say better with me. I live better with me. We have to be with the patient, and all together making a small orchestra improve your life, giving life to life of our patients with COPD. COPD, that disease that runs with a chronic obstruction of the airflow with permanent symptoms. It's a disease that is progressive and that is tightly linked with the tobacco consumption, although a series of factors, environmental factors, the air pollution, industrial pollution, exposure to the biomass, and a series of different aspects of the host himself, genetic alterations as the alpha-1 antitrypsin deficit, disorders of the development, accelerated pulmonary aging can predispose to that. And in year 2019 in Spain, what are the keys of COPD? Well, we are facing a disease that is preventable, tightly linked to tobacco consumption. With Professor Joan Soriano, who is with me this morning here in moderating this symposium, we estimate that between 80–90% of patients with COPD in Spain are or have been smokers. I've said there are also other factors, environmental factors, and from the host himself. And I also will say that COPD is not only tobacco. Professor Soriano, how are the figures of smoking in Spain at present? At present, we are worse than 2 years ago. The prevalence of smoking in Spain is 28% and is greater than with respect to the previous European survey on health, and is concerning the data on smoking in adolescents, even in children. The girls smoke more than boys, and we are around 30% of smoking in teenagers. And Joan, there other forms of smoking have appeared. What you can tell you about that? Both the e-cigarette or vaping and also tobacco that is heated, not burnt, are modes of smoking and using tobacco that have been introduced in Spain after having tried it in other European countries or in the United States by the tobacco companies. And these are damaging forms as any other of the usual cigarette, and we shouldn't be confounded, and we have to be very adamant with the use of these devices that are damaging for health. This message is extremely important, but we are also seeing another series of facts. The Scientific Committee of the National Strategy of COPD, we have incorporated a neonatologist. What does a neonatologist in a disease of elderly people who have been smoking for decades? Well, in Spain, we are attending an increase of the premature babies. Spanish women get pregnant at older ages. There are more twins. There are more prematurity. In fact, Professor Sanchez Luna, who is the person who has come to our scientific committee, is directing the HADIS registry of the Spanish group of bronchopulmonary dysplasia. This type of issues should be borne in mind as well. But in terms of public health, the binomial COPD and tobacco are always together, hand in hand. Another important issue of COPD is its very high prevalence. Well, in year 2007, we did the PISCAN study. The PISCAN study in the Spanish population between the age of 40 and 80, 10.2% of the population suffered COPD. 15% of males and 5.7% of women. 10 years later, and the database has been closed. In the coming months, we will start publishing the results of another large study, the study EPISCAN-2, that is done for the first time in the 17 autonomous communities in Spain, 19 centers from 17 autonomous communities. What does that, what can you tell us, Johan, about the EPISCAN-2? We can very little yet because the data are still being analyzed. But what probably this EPISCAN-2 will show is that the distribution and the prevalence of COPD in Spain is still one of the most frequent diseases in the adults, and that the underdiagnosis, that constant thing that we always find in respiratory diseases, and more particularly so in COPD, will be very high. There is an estimated data. The prevalence, we don't know it accurately, but probably it's around 10.67%. And in this case, without upper limit of age, those over the age of 40. And there is another indirect data as well, the percentage of the prevalence of COPD in women. The data that we have available say it's increasing. So this message that COPD is becoming younger and it's becoming more female-minded, well, it's a relevant message. Johan said that this is drama, the underdiagnosis. In year 2007, the underdiagnosis reached up to 73% of the COPD in Spain are not diagnosed. And we have hints that in EPISCAN-2, the rates of diagnosis have not improved. This is extraordinarily worrying for us, and later on we will talk about it with Dr. González Béjar. The underdiagnosis in Spain is greater in women. Why do we call it the Spanish paradox, Juan? We call it the Spanish paradox because in Spain it's the other way around than in the rest of the world. In the rest of countries, the other countries where we have done this meta-analysis, always the underdiagnosis is greater in men than women, except in most of the Spanish centers. We don't know exactly why, because Spanish women smoke as the rest of the European ones. Do they use other forms of heating their house as the European women, or even the prevalence of alpha-1 antitrypsin is similar as those of other European women? We are studying this right now, the Spanish paradox. Then we will talk about COPD and women and gender perspective. For that, we have Dr. Tamara Alonso, who is pneumologist from the pneumology department of the, another thing of the COPD paradigm of chronic disease, progressive disabling with many manifestations associated with COPD, to aging and smoking. Increases with age, and more we live more years. We'll live practically as much as the Japanese, Johan. We're also going to live even longer. In 2040, the Spanish longevity will go beyond, both in men and women, the Japanese one. But COPD kills and kills slowly. And in Spain, there are data that we have more than 28,000 deaths caused by COPD every year. Tell us something about the mortality of this disease. Mortality, this figure of practically 29,000, if we extrapolate it to one day, is practically 79 deaths per day, and one death every 20 minutes. This is one of the diseases or conditions that kills the most. But there are many people that die with COPD. In the death certificate, they don't say they die out of it, because not only is it underdiagnosed at lifetime, but also underdiagnosed at the moment of death. This is a call for all, for the health authorities, everybody, the impact, the enormous impact, health impact, economic and social impact of COPD. And consumes a lot of resources, and this is quite concerning, maybe for our political and health authorities. It consumes between 1,000 to 1 and 3 billion euros per year. That the most important aspect of those expenses are those derived from the severe exacerbations that derive into hospitalization. That is an important data. 15% of the patients, those of the summit of the pyramid of Kaiser Permanente, who consume 85% of the resources, and that do require innovative approaches. Those patients are stratified and are treated in a multidisciplinary manner as they should be treated. That's important. We live in a world where the chronicity, aging, the polymedication, the comorbidities are the keywords. And COPD, I insist, is the paradigm of chronic disease. Well, with, there are something that is contradictory in the Spanish system. We do fantastic things, and we still have pending tasks that seem much easier. Not a long while ago, we were having dinner with the current director of the National Transplant Organization. It has the best program of lung transplantation in the world, Spain. But we still do not do quality spirometry in many primary care teams in our country. We still don't speak to each other, the primary care doctors and the specialized medicine doctors. That coordination is failing. The continuity of the care is failing. We made a comprehensive process for COPD, but this is not enough. We have to implement it and assess it. And the assessment means that we have to have indicators of the process, of the structure, and mainly indicators of the results. We have to be intelligent. We have to innovate. We have to look for alternatives to conventional hospitalization. We have to implement the new technologies. We have to give the disease, the nursing of advanced practice, the critical role it deserves in the management of chronicity. We have to look for alliances with the pharmaceutical industry, with the technological industry as well, and mainly with the patients, above all, and the patients' associations as well, so that we have a long way to go in this direction. Because the patient-physician relationship has changed. It's not any longer a vertical one. It's a much more democratic relationship. It's a relation of therapeutic alliance, as Bercheville called it. The patient and his caregivers, they have to play a very active role because they are and what is comprehensive treatment and personalized treatment. And the integrated and personalized treatment includes the pharmacological treatment and the non-pharmacological treatment, in which we have fundamental elements at stake as respiratory physical therapy. Later on, we will talk about that as well. And then the world is moving. We read the journals of a greatest impact, and we have new scientific evidence appearing. Well, in COPD, we also have new aspects. At this respect, we already have available 3 therapeutic groups in one single inhaling device in order to administer to one of our patients. We have to study more and research more. And we have to research as well in the daily aspects, in innovation and in research in chronic patients. And we have to incorporate, there should not only be elite groups of research, we have to incorporate to primary care in these multidisciplinary groups of research. We have to change things. We have to look towards the future. And finally, COPD is still a great unknown. This is terrible. 2,200,000 Spaniards suffer COPD. They spend a lot of money, direct costs and indirect costs, intangible costs. 1.5 million are not diagnosed, and people don't know what COPD is all about. We coined a slogan, COPD seems to be aggressive, and the population didn't understand that. With Joan Soriano, in a meeting, unforgettable meeting organized by the Ciencias de la Salud organization, organize in Barcelona, we decided to write COPD with small letters. But the slogan is that COPD with small letters is a disease with capital letters. So the patient with COPD, and here we have two representatives of this group, is a patient, first-class patient who has an unmet needs, who has a series of claims that they are not giving any adequate response to from the administration side. Furthermore, recently some drugs that have proven to be not only efficient as to lung function, quality of life, reduction of flares and severe exacerbations, but also impact on survival. Well, the health authorities have placed a special certificate. The chronic respiratory patient is a very first-class patient. In order to receive that drug, they should need a prior authorization. But this is a collective task for all of us. And right now, I would like to go into depth in a topic that is very concerning. The underdiagnosis of COPD. I would like to talk with one of the primary care doctors who is with us, the most known ones, because she is one of the most representative figures of the respiratory group of Semergen, Milagros González Béjar, who is the director of the health center Montesa, that is, as 500 meters from this hospital. Milagros, with her, we have been working on many different projects. Milagros, how can we solve this issue of the underdiagnosis? Because we are quite concerned by it.
Good morning. Problem with underdiagnosis is quite significant for primary healthcare, and as Dr. Ancochea said, so right. Problem is that back in 2007 we realized there was an underdiagnosis in the IBER-EPAC study by 78% with EpiScan study. Way later we realized it was 73%, and right now with EpiScan 2, which has not yet been published, it'll go up to almost 81%. So we are doing something wrong. We're wrong about something. First, lack of coordination with the hospital setting from primary healthcare. We need to see and understand what's happening in primary healthcare as well. And first, we need to sensitize professionals about COPD, which is very much unknown, because if at the healthcare center, if we ask patients what they think COPD stands for, only a bunch will give us an answer about this disease, and yet patients want it diagnosed promptly and have the means, because since it is progressive, they want the means necessary so that they do not progress to thresholds where they need to be referred to hospital, which of course brings about worse quality of life for patients. So we need to understand its relationship to smoking. So first we need to have diagnosis through spirometry. We've fought, as Dr. Ancochea said, against authorities, and there's 90% of healthcare centers that have an spirometer, which is not enough. Having it, by the way, you need to use it as well, and it's all about sensitizing professionals, having the proper use done by nursing units. Patricia knows, they've come to be trained, and she's quite the expert in She's trained primary healthcare nurses for good quality spirometry. We need to have the diagnosis and understand how it is related to smoking. So we need to have smoking cessation programs. And when the person comes to hospital is because there's no other way around it. Maybe because it's a lack of compliance, or maybe because the disease progressed that way, and that's when they come to hospital, and then they'll be treated. But it is the same patient, so we need to have that multidisciplinary approach with all the professionals involved. Again, patients need to be properly diagnosed. That underdiagnosis, we all need to take the blame for it. So we need to understand that if patients come to us with basic symptoms, so over 35 years of age, coughing, shortness of breath, smoker, over 10 packets per year, we need to perform the spirometry and diagnose COPD if there was, and help them with treatment, inhalers, and proper compliance with the treatment. Yes, this message is a good one, not just for healthcare professionals, but even citizens who are over 35, 40 years of age, smokers or former smokers, over 10 packs a year, which is 1 pack a year per 10 years, especially if they have breathing symptoms, shortness of breath for exertion, limitation on physical activity, or that silly cough when they wake up, as John Manuel Serrat, the singer, used to say. Patients themselves need to say, hey, doctor, I need a spirometry with a bronchodilator test. We need to screen me for COPD. It makes sense that we healthcare professionals do it. It would also make sense that some goals would be included in the agreements for primary healthcare, have monitoring and have a head of COPD at every center. Well, there is, but they are not doing their bit. There's one at your healthcare center, but some other centers do not have it. Only recently, there is a center near this hospital where they haven't conducted a spirometry for over a year because they were missing a part. It's unacceptable. So, together, we will manage to reduce underdiagnosis. With Milagros and other panelists and many professionals, we developed the COPD healthcare program for Madrid. But there are also other regions that have it, so we need to guarantee the mobility, a shared patient where we have the GP and the specialist working together. Naturally, for COPD, despite comorbidities, it would be the pulmonologist. That's where we stratify patients. We have some which are low complexity, some others are high complexity. If they're high complexity, such as Esther and Julio with us today, Milagros refers them to the pulmonologist. And that's when Tamara Alonso, Dr. Alonso, starts working. She's in charge of one of the COPD monograph offices at our unit. She will introduce us to her patients, and they will have a discussion, and then we will have other stakeholders that are important for the management of Esther and Julio. Yes, that's right. Thank you, Julio. We now move on to another part of this panel. Dr. Ancochea, Dr. Soriano, and Dr. Gonzalez giving us clinical data, epidemiological data of the disease, scientifically very rigorous. But for this second half of the panel, we want to see the face and the hearts of the data, for which we are lucky enough to have patients that are committed with their disease, patients who are expert patients, aware of the disease, knowledgeable, that they have their daily battle together with us, and we want firsthand to hear it from them. And as Dr. Ancochea said, we have Esther and Julio, and not just them, but also family members with us in the room, because oftentimes COPD patients, they are part of our families. And apart from introducing them to you, I have a question for them. First question is, we talk about the lack of knowledge about this disease, the fact that this disease goes unnoticed or unknown by some people. So just shortly, I have two questions. First, did you know what COPD stood for? The first time you heard it, when we said you were COPD patient, do you know what it meant? And then, just in a few words, if possible, explain to us what you felt when we told you that you were COPD patients. The abbreviation, yes, I knew what it meant. But emphysema, that's what worried me the most. Emphysema, that was the word where I felt it going down the abyss, and then in short time, deterioration of my whole body. It was huge, and it was a mixture of feelings and not being able to control the situation. Whatever I used to be doing in 5 minutes in the past, well, it would take me an hour now. I could not shower anymore. It was such a deterioration that I cannot even put it into words. My eyes were just crying all the time, covered in tears all the time. And that feeling of guilt, something that I had caused and brought upon myself. The other diseases, well, they are bound by nature. But this, I had caused it myself. Julia, how was it for you? What was it like? I've been a patient at this hospital since 2014, but I came from private healthcare, so COPD, I already knew that word for 4 years. But then I'm a smoker. Well, I used to be a smoker since I was 12. I'm 78, and I quit smoking some 10 years ago. Problem, where is it? Well, as soon as you're told it's COPD, you say, well, there's no cure. I may progress slowly, but there's no cure for me unless there's lung transplant. But we don't make it into the list. Well, I don't know. I don't know if that's the good answer. Yes, of course, it answers my question. So you've entered quite an interesting concept, Esther. You talked about smoking. Yeah, that's right. This is smoking cause disease, and you might feel, I used to smoke. I've developed the disease, and at some point you might have that feeling of shame and guilt. Has it been the case for you, Julio? When you learn about it, yes, you brought it upon yourself, because I've never worked in settings with lots of dust, smoke. That's what I've been breathing constantly. As I was working, well, you could smoke on the plane, your car, at a meeting, your office. So you were permanently covered by a cloud of smoke on top of the smell that you were dragging around. And if we are to say with the data and the figures that we still smoke too much, that we do not manage to bring down smoking habits as much as we should despite COPD and other diseases, because it's not just COPD, there are many others that are the result of smoking. If you could talk to many people and give them a piece of advice regarding smoking that were efficient and good, or valid, how would you improve it? Well, go to high schools. As they just said, now the ages when people start smoking. A few nights ago, I heard that on TV. There was this subject, past midnight. This is a psychology TV show. The approach there was sex. Well, that was the topic. 13, 14, 15 years of age. They are having sex already. And they get talks on sex at high school. And yet, about this, there's none. So I would not mind sharing my experience. Because what's the point of me regretting it? Pointless. I have it, so. But I could go and tell them, don't do it. Of course, they'll do whatever they want. but show to them as I am, with the goggles and 16 hours a day. I need to be on oxygen. And this is what you would look like. I had to quit on sports. I used to go hiking, but I cannot do it anymore because I start getting shortness of breath and I get suffocated. I cannot even walk. I cannot even walk because if there is any stiffness, I suffocate. And so there's this we would like to know about. When we talk about COPD, we talk about many symptoms: shortness of breath, coughing, crackling, or whizzing. We would like to know about your daily life. I'd like to know about from both of you. What's the most important symptom for your daily life? What would you say, Esther? Fatigue and not being able to do things as fast as you were used to. I've always been in a hurry in the past, and now you feel limited. It used to be 5 minutes, now it's half an hour. If you wanna go somewhere, you need to plan to make it on time. As for daily life, I might not reach up to the wardrobe. I would get the stool and step on it. Now I need to ask for help. It seems I keep on needing someone. Self-care for a person is important. That decrease in self-care and autonomy, it's also having an impact. And as Julia said, starting out with kids as soon as possible. Many people, very cultured people, who've never heard about COPD. They don't know what it stands for. Lots of anti-smoking campaigns for lung cancer, but people do not consider how many other diseases are out there that are so disabling for your self-care, your freedom. They are crashing. That's the effect. If people truly knew that with smoking you burn not just your money but your health, that would be different, I guess. That freedom that we all humans need to live, you lose it. What about you, Julian? Shortness of breath, dyspnea, or shortness of breath for everything. I keep on suffocating. At home, even at home, as simple as that. Anything I try to do, I keep on losing my breath. So people say that rapid breathing or dyspnea is the most common symptom, right? That is the most damaging. Yes, that's it. Yeah, that's it. Esther, Julia said there's differences between genders about or sex-based differences in service. So women with COPD have a greater feeling of shortness of breath. They tend to be younger, smoked less. They have a similar obstruction despite they are the same age. And then they feel that shortness of breath more than male. Of course, we need to look into it and see what are the features here. But it is true, though, that women feel it worse going to surface. But I have another question, and then I will yield to Patricia, our specialism nurse. But I'd like to ask you one final question. We professionals working with patients that have the disease, we talk a lot about what exacerbations and aggravations mean for a patient's life, especially if there is a severe exacerbation and they need to be admitted. I like to hear it from you. What does an admission on exacerbation mean to you for a life of an COPD patient? Esther? Especially first time, second time. Yeah, that's when we got to meet each other, right? Yeah, that's right. Lack of knowledge, lack of control. You feel that choking and suffocation. You don't know why. and you get to the hospital, and they test your blood gases, which actually hurts a lot. First time was 3 days. Then on Monday, I was back on the hospital. What did I feel? I felt calm and at ease. I felt protected and secure. Someone could give me a solution, because shortness of breath, and at home say, breathe, you're not breathing. That's the problem. You cannot breathe. Simple motion of filling your lungs with air, crying and breathing, is a cocktail you don't know how to react to. You cannot stay in control. Uncontrollable, that is. Esther, I want to hear the truth from you. From that first exacerbation, from that first second time we got to meet up to now, it's been 5 years, right? Four. Well, no five, not 5 yet, but 4. You think we are doing better? We have better control of your disease? Even if we can do it even better. I felt cared for. I felt empathy from you. And then my dearest Patricia, I I can call her anytime. I try not to bother you, but if I see no other way around it, I do it, because someone told me that you need to to be a burden on your doctors, and I feel cared for. But as Dr. Ancochea said, oftentimes you come to the GP and they don't know what to do with you. They go into the computer and they check out the last admission. So they are overwhelmed to some extent with the situation. And you find yourself between two ends. Coming to the emergency room, well, you are not in such a bad shape as to go to the emergency room. And what about at home? Because they really get upset. And I think I'm doing way better now, especially knowing how to take control of those distressing times. Because psychologists play a role as well, by the way, and they pay their attention to us. We cry and go back home happier. And that's the time to give the floor to Julio, and we keep on. Esther and Julio, both, they've spoken first person. Only COPD people have that daily experience of living with COPD and knowing what the timeline is throughout the day. I don't have the air, I don't have the life, despite which they have resilience, and they say, well, by springtime I'll be better. I'll go out in the street. I'll spend time with my grandkids. It's only them that have the experience that we try to share with them, with everyone. From the Respira Vida chair, we've developed so many activities, some of which quite surprising. Music at the hospitals for Universidad Autónoma. On Sundays, there are concerts for our patients, caregivers, family members. We got people from Moscow. We got granted students together with Jonathan McFarland and Professor Soriano. We promote teaching, research, innovation for chronic respiratory diseases. But Don Julio said something very important. What about the 12 or 13-year-old kids that watch TV shows at night? And he's actually volunteered, you heard, to go to school. Well, we at the chair, together with a commission, we will be visiting those schools. Here, this is the room where we had the first Respira meeting or workshop organized by the CEPAR in Spain. And so we have the first workshop, and we had 200 kids who are 12 and 14, together with the Ombudsman for Minors, and that first lecture was on preventing smoking. We will publish some 25,000 copies of our first book. There are some people of Asturias here, and it will not just be Galician or Catalonian. We will also have the Asturian language for this book. Take it to the school so that kids say no. Prevention. And data are quite concerning for boys and especially girls now, as Professor Soriano said. And well, like this, we can also have two associate lecturers from the Universidad Autónoma working with the chair. One, you just heard her, Dr. Tamara Alonso. The other one is a nurse, a specialist nurse, Patricia Perez. Patricia's role in this orchestra is basic: closeness, proximity, on the other end of the phone, person that comes and visits me at home, that gives me support and care, who gives me her love. Patricia, what's your role? And please, talk to your patients. Good morning, thank you, Julio. My name is Patricia. I work with the Pulmonology Service, and since 2011, I'm part of the PAPA program, which is early warning for respiratory patients at the Princesa Hospital. And that's when I met Esther at her place, as well as the self-care consult office for respiratory patients that I'm in charge of. So when patients cannot come to hospital, they come to my office so that we can work on self-care and healthy habits and healthy lifestyle they need to have to get improved. In 2015, Dr. Tamara Alonso at the ER referred me to Esther, to her home, and that's when we met. First visit was long because she had called the ambulance, she was not feeling good, it had been a terrible night, lots of shortness of breath, no resting whatsoever. So I came by her home as the ambulance was coming to help her out, and that's when we met. And we started out roughly lots of home visits and staying together, talking a lot, and bringing her ease of mind in her concern and new pathway she was exploring with her family. And I guess that even if it was difficult as a start, we've had a beautiful relationship. That's what we have now. Julio, I met him a few years later. I think first time we met was a walk organized by SEPAR for patients, and we walked around the city center, and then we had some churros. And I think we've stayed in contact through activities and just a few visits, because there's not much exacerbation for him, but we stayed in contact all those times with walks and the patient conference and the talks and lectures organized about inhalers, and also a workshop on physical therapy that we threw and put together and very much visited. And I work with home visits for exacerbated patients that come to the ER most of the time, as it happened with Esther. I check out the exacerbation and stay in direct contact with the pulmonologist, and then especially I work on promoting self-care, independence, healthy lifestyle, inhalers as well, which is basic part of the treatment for COPD patients. I check them using inhalers. If they need to be changed, I discuss it with the pulmonologist so that we adjust the inhaler, the one that is best suited for the patient. We also talk about respiratory physical therapy, oxygen therapy, as it happened with Julio, how he was using oxygen therapy. You remember, Julia? So I want you to comment on everything that I've discussed with you. Julio, remember that problem you had with oxygen as you were used to use it? What was your problem? I've been prescribed. Well, ever since I came to the hospital, because in the past I was not coming here. So it was 2 hours oxygen at home. Here I was given 16 hours. My problem there was going for a walk, going out and exercising. Another topic that we could discuss. But out in the street for a walk, I take my portable device as well so that I can breathe. I used to have a machine at home from the beginning, and all of a sudden it was noisy. Despite going to the manufacturer, well, they were not paying attention. And the noise was upsetting for my neighbors at home. I was using my portable device at home. And you told me that's the wrong way to do it. You need to have a device feeding you oxygen constantly and not a pulsed version as the portable one. That was it. Oftentimes, as we prescribe inhalers, oxygen, oftentimes we take it for granted that patients need to know how to use it. And that's where we have to do a good deal trying to explain to them how to use it, when to use it, when they go out, when they are home, when they are sleeping, and also reinforce self-care. People forget about it, and maybe they don't know how to do things right. And with Julio, that was the case. He was using a pulse device for sleeping that was not feeding him enough oxygen, and inhalers as well. At the office, inhalers been changed for him and reinforce it, and we summarize again the inhaling technique. Used here throughout the time, you've had several inhalers we've changed. What about them? Best one for me is the chamber inhaler. I feel safer that I've done it all right. And then oxygen. If I'm resting, I don't need it. I use it after lunch because, as I was told, when you use most of your oxygen is for digestion or sleeping. And I would raise an objection against this ice cream cart we drag around behind us. Maybe we need an extra battery or more length or duration, because you go for lunch out there and you want to stay with your friends, or you go to theater or whatever, and you don't have that much time. You feel, will it be enough or not? And so this is something else we would need some improvement on. Yeah, that's what I've claimed before to my specialist. The manufacturer was allowed to add an additional battery. And this is part of my report. I've given them a call to the manufacturer, but he was not paying attention whatsoever. Again, I was stubborn, he was a stubborn, but you run out of oxygen and after 2 hours, and what's the point in dragging it around with 4 kilos and pointless? Again, if Teresa allows me, let me reiterate that we need to do, or even if we don't feel like it, but breathing physical therapy is important. Even if I'm just in the kitchen, I keep on feeling it, my belly up and down, in and out. But some cycling and walking, as they say, helps us. I believe what I'm told, and I try to do it.
Well, since we know each other in the very hard beginnings, and when you didn't believe you were able to do everything you are doing now, you remember, we forced you to go to the beach, to yes, it was an obligation under prescription. At the end, in your mind, a change has taken place. We, you told me you hadn't accepted your disease once, and I'm not accepting it, but I know I've got it, because it's very hard to accept it. But yes, we've seen a very important change in you, always with the support of your family. This has given you the feeling of that you have limited or cut the wings to your family, but I've always seen your family and the wife of Julio the same, walking nearby without, but not sometimes not so that often. We all get tired, of course, and this is part to the fact of the beach. We could talk about that. When we came out from Madrid, is if it is as if we went abroad. Here we are protected by you, but you have learned how to also walk on your own. Although you know that you have our support, you have known how to be bold and go out, and realize that you can go out and take away that fear. The first time we told you you had to go to the beach and leave, you were very afraid. You went there and you came 2 months after. You were 2 months on the beach and you were absolutely new. Apart from the pneumothorax, I came back on the 24th of September, but it happened to me on the 23rd. But this was later. You did manage the situation. That's why you came back to Madrid. You knew that you had to be close to us. But yes, there has been a change. It's there. I think that all those things that we tell you at home, in the office, and your when you do the gym, have been you have paid them the proper attention, and you have noticed, because we have noticed it as well, how your situation has become better. In spite you have your dyspnea, but how you are able to keep on leading a quite your own life, being able to enjoy leisure time and go out and the day to day and recover somehow your own life, although it's not the same as it was before. I was riding on a bike last summer, but now you are on a static bike. You don't move from home, but you can still ride a bike. Yes, you enjoy the bike, but you have known how to adapt your life. And this is also very important, to adapt your daily life to your own situation and keep on enjoying it. I think you have achieved that, and it's not always easy. You have to, either you take it or leave it, but you have to adapt. Otherwise, either you just stay there and don't do anything and are disgusted, but or you should change. I give you right, but it's not easy, and you have been able to do that, both of you. And I always tell you that although it's hard, you have to keep on doing it. We have to keep on living and give high quality to our life. But we have our days, Julio, and you have the right to have those days, of course. But in spite of having those bad days, you still keep on fighting and giving quality of life to your days. And our problems with those who protect us. But this is part of life, to have somebody to whom to argue with. Well, if you see it like that, maybe it's time for separation. Well, this is our goal. Give life to life of our patients with COPD. And that's why it's so important to diagnose them early, not when they already have very deteriorated lung function. In the giving life to life, we have drugs and drug combinations that have proven to improve the quality of life. The St. George questionnaire and the CAT have proven to improve the lung function, to stop the reduction of this lung function, reduce the exacerbations, reduce hospitalizations, and even improve survival. But to this pharmacological treatment, nearly as important or even more than the pharmacological treatment is the non-pharmacological treatment. So in this panel, we don't all have room in it, but there should be a nutritionist. The issue of the nutritional aspects in COPD is extremely important. Our psychologist was unable to come, David Rudilla, who's a crack. I mean, he's fantastic, because behind Esther and Julio, there is a person, not a patient, not a disease that is called COPD. There is a person who thinks, feels, and cries, etc. Sees herself limited, lives in an uncertainty situation, wants to do more than what she does. This person sometimes, her psychosocial sphere is also affected by this. When we have a patient, we have the physical part of him, dyspnea, breathlessness, but we also have the psychological aspects and the social aspects, and also the spiritual aspects. That holistic concept of a person, that's where humanizing goes towards, to where people working for and with people, and those people always need us. And we prefer healthcare providers, we also need them. My name is David Rudilla. I'm a psychologist. I work in the pneumology department of the University Hospital La Princesa in Madrid. Well, I work with respiratory patients, both COPD and other pathologies, but basically with COPD patients. How does a disease as the COPD have an impact at the psychological level? We have to bear in mind that a disease as COPD are not only physical symptoms as the breathlessness, dyspnea, there are symptoms, psychological symptoms, anxiety, depression, even psychological aspects as insomnia that has a great impact. But it's a disease that also has an impact at the social level with isolation, alteration of the social and family relationships, and then an impact, the most psychological part of it, more essential of the person, the essential dimension, impacts on hope, dignity, the consciousness of ourselves. It has a very great impact. It has all your feeling of yourself. That is something that we have to bear in mind. The consequences of a disease as COPD goes beyond the symptoms, physical symptoms, and affects emotions as well. And emotions vary from day to day, and the emotions help a person to be able to be better or worse. It has a very serious impact. And something that I always say, I comment to everybody when I explain that I work with respiratory patients with COPD, the lack of air is one of the most terrible symptoms for a person. I always say that the most terrible death is when you die being burnt and you die because you drown. Those are the two deaths that everybody shares. It's a great suffering, the lack of air. So we can understand and we can see at the psychological level what it can imply to have a disease where not only the loss of autonomy because you can't do things, but live with that feeling of being unable to breathe. You are nervous, and at the end, the person ends developing a lack of motivation, and she's not completely depressed, but this feeling of failure that the COPD is consequence of life habits that have not been healthy enough. And then the blame, the guilt is something that is there as well. That is something different that we also should talk about, that lack of hope and discouragement. There are many points in time in COPD where the person now you have to have oxygen and then you have to renounce to this and that. This is a disease where your life becomes losses constantly. You have to assimilate the losses. How is this going to affect at the psychological level, of course? And then something that was, of course, the great impact when I started working with COPD patients. The patients are hidden, so to speak. They are more very much at home. We don't see them. It's the patient who talks about the paradigm. We talk about chronicity and heart failure, but the patient with COPD is a patient as he's at home who depends on oxygen now. He can go out with the portable oxygen, but he's a patient who is not visible. It has a social and personal connotation that is very important, very negative, by the way. It's necessary to work on it clearly with the patients and their relatives. How can one improve, or how can one improve the patients? Or what can we do as psychologists? There are many forms of approaching the health psychology. It has not too much to do with the mental health psychology. The problem is a real problem. It's a problem that we can't say to a patient with COPD, don't worry, nothing happens, because the patient feels it. We can't say that to a person who has a real problem. I have I normally approach the patient in a humanistic manner. I'm not looking for the pathology, I'm looking for his strengths in order to be able to build from their own. All patients forget that they are people. I say that very often, the word patient. I want the patients to enter the office and become persons. There is one whole day that I dedicate to people who come to the office to talk about who they are. I talk about their philia, phobia, their passions, what they don't like and what they like, what they've done, what they would like to do, because I want that Manolo is Manolo, that Esther is Esther, that Paco has to be Paco, because they have forgotten about that. And they are surprised. And What have we been speaking about today? We have been speaking about you. From there on, a person is aware of what she has and what she has lost, and that's the second part we have to work on. Despair and demoralization. The human being has always hope. And although we are adaptive by nature, we always we expect a miracle even. If people, if we buy lottery, all of us, to show that we have probabilities to win lottery more than curing of a lung cancer, how can't we expect to get cured? Of course, we do that type of behavior. We have to adjust the hope to real objectives. And although I can't run the marathon, this doesn't mean that I can't go out if I organize my life in order to be able to go out on the street. What we renounce to, we have to change them for something else. And this is something we work very much in consultation. It's very interesting to see how people who think that the only thing they are doing is losing their time in this life, they recover it with small goals. There is a very important part to it as well, and I'm working very much with the COPD and this characteristic, and it's blame and guilt, because Harper said that for pain there is anesthesia, but there is nothing for guilt feeling. There is only released when there is a repair. The person who has smoked for so many years has COPD. She thinks that she deserves that, and as I've done this, this is the example I've shown my family. We have to work very much on guilt, and we can only release when we pardon ourselves. And this is not easy, because when this is put together with shame, it's an assessment of the self that is very negative. I dedicate a lot of time to the patient with COPD in working on the issue of guilt. And then another aspect I'm obsessed by this issue is dignity. There is a question that I'm always asking all people who I see. What do I need to know about you to give you the best possible care? The best her best relative is Margarita, or that she loves the beach, or that she wants to die, or that she wants to get cured. But what do I need to know? Maybe she says that I'm deaf, I can't hear too well. I'm ashamed of doing that, and sometimes I just make up that I understand. And from there on, can build the dignity of the person, because a person with COPD, we have to. I'm very happy in La Princesa, because I believe that at the end the psychological doesn't only belong to the psychologist. Everybody participates there. Then I can do a more specific job that has to be done. Not everybody can be a psychologist, and not everybody can be a physician, but everybody is asking this to patients who have COPD. We are going to be able to make them think about their dignity and think ourselves about their dignity in a much more proactive manner. It's very beautiful, and we all thank it when somebody remember something from you. How was the marriage of so and so? How we feel listened to, and that's what we have to do with a patient with COPD. What advices would you give a patient with COPD, David? Well, to give advices is complicated, as my mother used to say, especially that they shouldn't think about themselves as patients. The first thing, they have to think about themselves as people, persons. This means to recover everything they are, retrieve everything they are, from what they like to what they don't like, and they have to go with that throughout life. I think it's important to give permit to yourself and give permit to feel bad. As we are old people, we can't let emotions flow. Sometimes it's better for the emotions to flow. When they flow, they have less track than when they just let them from time to time. Then they are manifold. A person that claims the psychological attention of the persons who have a disease, will have to tell us that. They shouldn't be. Well, what I'm obsessed with is when a person with COPD thinks that she doesn't have anything to do any longer. They have to think about everything they want to do, and among all of us, have to be able to make her do things. There are things that we can do that they cannot do. They can't run a marathon, but they can do many more things. Always think about what I really can do. Realistic goals is one of the best things that we can do for oneself. Well, within this orchestra, where nutritionists, the psychologist, together with the nurse and the primary care physician and the specialist, there is a very important role for physical therapy, respiratory physical therapy. We are lucky to having in our group Maria Teresa Hernandez, who is a physical therapist. That is fantastic. As the COPD patient is a first-class patient, you are a first-class physical therapist. You're going to show that now. You're going to tell us with a series of exercises and some slides as well. Well, Teresa, we are always looking for Teresa. Where is Teresa? When this symposium finishes, Teresa, Patricia and Tamara will make a workshop of respiratory physical therapy within Respira Vida chair for a wide group of patients. But Teresa is very important in this orchestra. What can you tell us? Well, first of all, I would like to thank you, Julio, because I'm in respiratory physical therapy thanks to Julio and his drive and having the luck of knowing patients as Esther and Julio as well. It's always a pleasure. Physical therapy is always known due to the osteomuscular topics and issues. Throughout the years, it has changed. The approach of physical therapy has changed. We've seen the great weight of patients for the respiratory problems. The scientific evidence, as Dr. Ancoichea said, has shown us that if we do work with the respiratory patient on his quality of life is improving very much, although the spirometric value doesn't improve, the patient tells that he improves significantly his quality of life when he does training to effort training and physical therapy exercises for his breathing. How do we focus the treatment of the patient? What can we give the respiratory patients within uh, this whole set of these different experts? We work on three main aspects. The first one, we collaborate as the rest within therapeutic education. We help the patient to understand what happens to him, why he feels breathlessness, what is breathlessness, what is happening in his lungs, and why can't he lead a normal life. But why is he snake when he does the activities he did before? We try to explain how this affects his musculature, what is happening at the osteomuscular level, what happens and why does he has muscle cramps and why are his muscles hurting when he does the activities he did before. We reinforce and we make him understand the importance of nutrition. This muscle has to be very well fed so that when we start making it exercise, it improves its effectiveness and it is able to make exercise with less cardiac output and oxygen output. And we teach him to live together with this dyspnea, with this breathlessness, and understand when he feels that sensation. Not always do we have to stop. Sometimes we have to do things slowly and organize yourself differently. And this is something that we do on a daily basis when they are under our treatment. Try to give them positive experiences because we only learn through experience, and what they do feel and they do experience when they work and do physical exercise. Although they feel some breathlessness, they have to be able to understand that they see that they can go on biking on the static bike, although they feel that, and this allows them to keep on working and adhere to what is so effective as is physical exercise. All this is done throughout all sessions that we have to do with them, with the workshops. This is a very important part, as Patricia said, to speak with the patient and to explain to him and make him feel things so that he may understand them and then internalize them and live them. And then we do something else. We work on another field, respiratory physical exercises, where we show him clearly how he has to inhale air, how he has to expire the air, so that work on the respiration so that it is more effective, so that he's less tired, less times per minute, in order to improve the elimination of secretions. We teach him to not be in anxiety and anguish and be relaxed through respiratory techniques. And then we work on the last aspect, that is the fundamental pillar, physical exercise, physical activity. As we study the COPD, we discover that it's having more, the fact that the patient moves has the greatest weight. Having a similar spirometry, one similar to another patient, the one who is in movement, the one who goes out, the one who does things, has a better quality of life and better prognosis than the one who is sitting in his chair at home. And this is a fact that is undisputable. So when Esther has mentioned, well, you tell me it's good. Yes, you tell me it's good. You have lived that, yes. Then, of course, we have to move. And we do show them, we start them moving, as I'm going to do now. I'm going to make you move. When you are in contact with a physical therapist, that is, he puts you to work. No, it's not only to listen to him. How do we work with them? What's the first thing we do when we start training the patient? The first thing that he does when he comes with us in the room, we teach them this: the importance that hand hygiene has, or any other technique of cleaning in order to prevent contagion. We teach them good hand hygiene and measures to prevent contagion. We also teach him to how they have to take their medications always before exercise. The issue of oxygen, they removed it to do the bike exercise at home. They only put the exercise when they were watching TV. Teaching them the proper use of oxygen therapy, or always work in coordinated fashion with nursing and pneumology departments to try to organize their daily activities around this breathlessness, but without living it with anxiety or anguish. You have to learn how to breathe whilst you are taking a shower. You have to learn how to breathe whilst you are cooking. But this doesn't mean that you can't do it. You have to do it in a specific manner. And this is taught in the daily practice. We do from workshops that, as the one we will have in the Respira classroom today, to the training groups for effort training that we do for 2 months, until respiratory physical exercise in a group in the ninth plant of this hospital. We do a lot of education. We believe it's a fundamental pillar for the patient. The patient has to know what is happening to him. He has to understand it, because this is what is going to allow him to adhere to the really efficacious treatments. And then the second part, where we teach how he has to inhale air. He has to use his nose, his mouth, the transverse muscle of the abdomen, and mainly this one, the head, his mind. He has to be calm and comforted. He has to control and do voluntarily the use of his mind in order to prevent that cycle of anxiety. I can't go on. I have to phone the emergency department. We have to breathe. We have to stop, but we have to breathe slowly, not rapidly. And we are going to do that every day. In patients, when they come from their home, we teach them where they have the diaphragm, what we have to do with the diaphragm, how they have to take the air very slowly through their nose, how they have to maintain it inside, prevent to do hyperventilation where the air is not maintained inside. We have to, here you can see pictures. It says 2007. We have pictures from 2005. We have been working with the patients for a long time. You practically know them all. So once we teach them how they should take that air, we are going to teach them as well to expel the air, and to blow out the air, because they have problems to inhale the air. They can't put air in their lungs. But what is really the problem? The problem is that they don't let the air coming out. They don't expel the air properly. So we practice very simple exercises where they see that during a long time, much longer time than what it takes to fill the lung, they have to be expelling the air. The first time we give them a straw to blow in a glass, and now take air and keep it inside, and very slowly make small bubbles during as long time as you can. And we show how long time they do that. What happens? They are much more time than what they have been inhaling the air, because they have a lot of air inside that is not efficient, that is useless, and we teach them how to eliminate that air, doing something as simple as this. And we teach them to do a slow expiration that is deep, eliminating the hyperinsufflation, this air that is inside the lung that is useless, that doesn't allow the lung to be filled efficiently. And then the secretions have to be expelled outwards, and this slow inspiration with the glottis open without causing a cough, because coughing is only efficient when it's over the upper part of the sternum. The mucus that is inside, that doesn't come out when you cough, but it does so when you have the glottis open. And all those things are learned, and once they learn them, they use them in any place. We teach them the positions where it's easiest for them to work for the diaphragm, in which the dyspnea seems to be more difficult, or when the dyspnea appeared because they have been going up a hill or an aggressive activity, they can place themselves in such a way that it's easy to recover their breathing, fixing their arms. All those things we work on them throughout the sessions so that they can have always an experience of what we want them to learn. They have to practice, they have to do it in order to really be able to do it in their daily life. The other day in the group that we are working on now with Enrique and Patricia was with them the other day, one of them had a breathlessness crisis. And I don't know if you were there as well. And I was about to phone the emergency department because I already had the feeling of loss of consciousness. And Teresa, I don't know where the voice of Teresa came from, but breathe, breathe, be calm. It was not a miracle. This is how you re-educate or retrain something. You repeat and repeat and repeat, and then it's recorded as such an automatism, and this is something that she knows how to use when she needs it. This is what our work is all about, to repeating and repeating, and at the end we are able to reach the goal. And the most difficult part for them, they get they gasp for air, and they still have to do exercise nevertheless. And they always say the same: when you are there, when Mrs. Rottenmeier is with us near your bike, you can put up a little roar, more rapid, or I can put more resistance to the bike. Just 5 more minutes. I have to do that, but when I go home, nobody's forcing me, then it's much more difficult to do that, to be able to keep on doing exercise. How can we able to achieve that? Through this experience. They have seen that they can do that. They have entered with this breathless situation of 3 or 4 in the Vorst scale, and when they go down from the bike, they have a feeling of 2. They have less sensation of breathlessness after having been on the bike, and they have to live that. They have to feel that, because that's when they will go up on the bike day after day. And this is what we try to do with them: help them and sharing with them that experience. And they do share them among them, and they have a nice time together. They are a group, they strengthen each other. Then they have let's go try to go to that gym. They socialize with people that are as they are, that gets tired when they walk, as they also get tired, and this is very important. And well, here you can see pictures of how the training sessions are. This is a picture of a program that we started in the hospital. Uh, Early physical activity onset in admitted patients. As soon as they were admitted, their respiratory function was better. They received all the therapeutic package, but they stopped moving. So they worsened their capacity of doing aerobic exercise. So when we saw that making a little physical activity during their admission, they didn't lose that gait training, etc., we started working on that aspect as well. Here we can see a different type of patients doing all these activities that we put them to do. Well, something as simple as this band, this rubber band, that can give a very important physical activity, especially for the upper limb. This is a fundamental part of the chest that is going to allow us to open and make flexible all the ribs, expand the chest, that is the one that is pulling from that lung. And how can we make them work? We ask something as simple as this. They have to pull from a rubber band, but always in a special manner, breathing as we have indicated them to do. They have to work on all type of muscles. We work very much on the upper limb, and now some exercises for the lower limb. But we will always ask them to breathe in a controlled manner. They always have to take in air at the moment where we are at rest. They have to maintain the air inside. The moment of apnea is very important. And then always when they do the effort, they have to blow out the air so that the fatigue and the breathlessness don't appear. And we have different exercises, 10, 20 repetitions. Always focus on the needs of the patient. The patient gets gasp for air when he's having a shower. We work more on the triceps or more on the muscle elevator muscles of the arm. The one that is patient that has to cook and has to take things from under the table, we have to make them do other things. Something as simple as making this gesture, squatting, yes. It looks like when I blow out the air. It allows us doing X repetitions a day to improve very much the capacity of the patient to do physical exercise. And we tell the patient he has to do aerobic exercise. Aerobic exercise with a rubber band, in a belt, in a treadmill, the static bike, or just we can see this the picture of the patient Argimido. I showed it to my mother. This patient is 91 years old and is keeps on biking. Pedalier is very easy to have at home. It's a useful tool that has shown its efficacy with patients with diabetes and any other characteristics. This is something as simple as having it hidden under the table whilst he is looking at watching TV. He can be pedaling there with this pedalier, this machine, and be there for half an hour, three-quarters of an hour, 10 minutes in the morning, 10 minutes in the afternoon, what he can. Don't tell me this is difficult. Anyone can do that, and has to be proven. They have to experience that in order to then do it. And when they have experienced that, as Archimedes, they don't stop doing it. In fact, I think they become addict to exercise. And there are some that always do that. They never stop doing it. Apart from training them and teaching, we will have to be able to make the next step. That experience has then to be transferred to the activities that make them happy, that fill their life with happiness, that gives them gratifying experiences, exercises or activities of their daily life, from going out with the dog until being with your friends to play cards or whatever, or go to play with your grandchildren. But what is efficient is to increase the amount of physical activity they do in their daily life. The greater amount of physical activity hours, the better prognosis for the patient. But they are also happier, or aren't they?
It's not about filling up the day or filling up the hours, but it's about living. And as we were saying, breathing control at all times to make sure there is no shortness of breath, and if it happens, keep control over it, and remind patients that, well, let me remind patients that there's this website where they can check all those exercises free of charge on the internet, because we've developed them for them. That's been all. This is Artemiro's picture given by Patricia, proving that you can be 91 after 8 years working with me. He keeps on exercising. But it's not Artemiro's picture only. We will play a video as well, recorded by Patricia yesterday, where they talk about you. I met Artemiro when I was a resident, if I'm not mistaken, and he's 91. So, see, a COPD patient can live and make an effort every day. Video, please. Argimiro, I'm pedaling here. When do you do that, Argimiro? When do you use the bottom bracket? In the morning. Every day? Every day. How long? 15 to 20 minutes. Some strength, right? Yes. Yes. You need to tighten the screw. How long have you been using the bottom bracket? 3 years and a half or so. All right. And what's up in your hand? And breathing incentivator. Is it? When do you work on that? Early in the morning as well. Sometimes in the afternoon, but not so many days. After I'm done with the bracket? You mean what do you mean? Oh no, when I'm done with the exercises, I work with incentivator. What exercises do you mean? Many different ones. Do you want to show that? No, just tell me. Knees, bands for the arms, diaphragmatic breathing, hands up, But controlled breathing, right? Yes. Good. Same as in what I used to do with Teresa. I think she was one of the best ever. Well, that's my choice. She is a good teacher. She is. Because you keep on exercising every day at home, and that's very much important. Yes, say hello from me. How old are you, Argimiro? How old, you mean? 90. 90? And see the speed of your pedaling? Say hello to Teresa. Say hello, Teresa. Hello. You know, I'm very happy with you. See? Living with COPD, bringing life to life for our COPD patients. This has been a wonderful workshop. I really enjoyed it with you, our patients, and I hope that it's been useful to all of you. And well, that is, it's been up to the standard. Our second conference. Thank you, Soriano. Thank you, doctors Perez, Alonso, Hernandez. As you can see here, we have a huge orchestra playing a symphony, conjugating concepts and feelings. And then for chronic respiratory patients or COPD patients, what they hear is, we are with you. That's the name of the workshop. With you, I live better with me. Thank you very much.